Good evening, everybody, and welcome to our annual public meeting and members meeting for Oxford University Hospitals NHS Foundation Trust. My name's Jonathan Montgomery, and I'm the chair of the Trust Board and also of the Council of Governors. Thank you very much to all of you for joining us. I'm sure in the audience we have members of our Trust staff, we have members of the public, I know have members of the Council of Governors. We will have key partners in the health and social care system, all working together to meet the needs of patients. And we're expecting about 250 people to join us, and many more people will be able to watch the recording afterwards. So thank you very much for joining us. Despite the impact that COVID has on our operations, we're delighted that we're able to share this meeting with you and say something about the year we've had and the work that faces us. On the next slide, you'll see a picture of all the board members. You'll see two new faces. The governors have appointed Ash Soni and Joy Warmington to be non-executive directors since the last annual meeting. Joy is unable to be with us tonight, and we're also without the Chief Medical Officer, Megan Pandit, this evening, but Annie Sykes is here on her behalf and if necessary will be drawn in to answer some of the questions. I'd like to thank all those colleagues on the boards for all the work they've been doing to support us over the year, and in advance for answering questions that you have sent in or will be putting up on the Q&A function during the course of the meeting, and we'll pick up those questions at the end of the presentations. The most important thing I'd like to do at this stage in the meeting is give my thanks to all the staff who work in the Trust. To our colleagues at the Oxford Hospitals Charity, who once again have given fantastic support to our staff and patients throughout the year, and everybody who makes this meeting possible. It's been an unusual and challenging year, and I'd now like to invite our Chief Executive, Dr. Bruno Holthof, to remind us of what the year brought and say something about the plans for the future. Bruno.
Thank you, Jonathan. What a year it was indeed. I think for all of us, when we went into the pandemic, we didn't know what was ahead of us, and we're now sort of in the midst still of a pandemic. We're not at the end yet, and it has been a tremendous challenging year for our staff and our patients, and I would say probably everyone around the world. So I want to reiterate your thanks to all of the staff members. We've called it One Team, One OUH, which was maybe the good thing to see in terms of the response to the pandemic, how we all pulled together to keep each other safe, to keep our patients safe, and to keep providing excellent services where we could. And certainly in the first wave of the pandemic, we had to cancel a lot of diagnostics and other appointments. And I understand how difficult that was for many of our patients. After the first wave, we started recovering from the first wave. But as we all know, we had several waves of this pandemic, and it's still not over. So I'm extremely grateful for the staff who have worked tirelessly 24/7 to keep as much of the services going as possible and to also deal with the COVID pandemic. You mentioned the charity and lots of other charities and donors who've been wonderful during the pandemic with support in kind, in person, which was wonderful to see how the community pulled together to help us through this difficult period. And I'm also very grateful for the students who probably didn't expect this to happen, but probably had a tremendous learning experience, but were extremely willing to step up and help us do, for example, testing of staff and patients, helped us with a lot of the clinical trials that we were running, which was a tremendous effort. And people really went beyond what we could expect from them. We also had some great successes, thanks to our research colleagues. Of course, the vaccine is well known, but we had some real breakthroughs from what we call the recovery trial, looking at which treatments would be effective against COVID. We had some great research in testing different types of tests and how to apply them and what we could learn from the diagnostics. So it's been a tremendous contribution from our clinical academic colleagues who've been also very busy 24/7 trying to fight this pandemic and find solutions that we're now all benefiting from. So clearly the year was dominated by COVID, and we're still dealing with COVID as we speak. But the first message is a big thank you to everyone who pulled together in this difficult period. Next slide, please. I also just want to take a moment to remember some valued colleagues we lost during the pandemic. We also had ways to remember them during the past year, but it was a very sad experience, I think, for all of us to basically lose people that we work with closely day in, day out. And that certainly was one of my low points in the past year. Very sad moments indeed. And I mean, it's been tough for all of us. And one of the key priorities we had is how can we come out of this stronger? What are some of the things we can learn from how we responded to the pandemic? Some things that we can keep. Some things we've done actually work pretty well, and we would like to keep it. We've also been quite innovative in ways we responded to it that could be applicable to other services, but certainly over the past summer, we've given people time to rest. Very important that people could take their annual leave so that they could also reflect on what happened and also take time to recover, which is very important. And we had and we still have a strong program, to support staff to come out of this stronger, with well-being check-ins and lots of other things that we're doing to make sure that staff are feeling that we are fully supporting them, but also that they can grow and something good comes out of the past year. Next slide, please. It was not all COVID. During the past year, we've been quite active in investing across our different sites in better spaces, new equipment, new services to deal with the future demand. Catherine House has joined us and complementing the Sobel House in providing a service across Oxfordshire, a highly needed service in terms of end-of-life support. And we've made some very important investments in the past years, and this is a continuation of that sort of development of an important service towards the end of a person's life. We've also made significant investments in emergency care. For those who have visited the recent ED department, recently visited ED departments at the John Radcliffe or the Horton, will see that they have been significantly expanded, renovated, lots of new equipment, diagnostic equipment, etc., to deal with the increased demand in emergency services. So that's been good to see that completed in the past year. We've also started work on some important other sort of extensions, a new hemophilia and thrombosis center at the Nuffield Orthopedic location. There's still construction going on. You'll see a purple building that will be cladded, and it will not remain purple, but that's the new critical care building with a significant sort of capacity, which will also, of course, was built in the context of sort of preparedness for potential future pandemics as well. We've really invested in the respiratory unit, again, in response to COVID, quite useful for the COVID response, but also will be investments that will be important for the future. And then I'm happy to say that the works at the Swindon site of Great Western Hospital for radiotherapy have started after many years of preparation. And again, it's an example of how we're working with partners to make sure that we can provide care as close to home as possible. Next slide, please. So we have been doing lots of celebrations in the past year because we have wonderful staff. And one of the celebrations that really is working very well is the DAISY Awards and what we call the Oxford Scheme for Accreditation. And we also have a system on reporting excellence. We do get complaints, but we increasingly also get lots of comments on the excellent services that we provide. And so the combination of DAISY Awards, the OSCA Awards, and the reports on excellence really are motivating our staff, especially in challenging times like we're currently operating in. It's nice to get a compliment. It's nice to demonstrate to staff that we appreciate the efforts they do and that they provide some excellent services to our patients. In addition to the internal awards, we had many external awards. We would need several PowerPoint slides to list them all, but it's always very great to see that we are recognized externally for the excellence we provide. And then we have sort of bundled lots of the stories from the COVID pandemic in an ebook, which is already available, and you see how to access the ebook if you haven't done so already. But it captures great stories from staff and patients and volunteers, sort of captures the essence of what we've been living through in the past year. And I would highly recommend, if you haven't done so yet, to just go online and read through the stories and look at the pictures. Which leads me to my last slide, which is an announcement that we will capture some of the images from the COVID-19 pandemic in a hardcover book, so a real printed book. Staff will be able to order the book and keep it as a memory of what probably has or will be one of the most challenging years in our lives, unless we're faced with an even more severe pandemic during our lives, but hopefully that's quite unlikely. But it's been a year beyond words, and we've asked staff to send us in some of their most memorable pictures that they've taken during the year, and we're going to bundle it in what hopefully will be something to remember, and hopefully remember some of the good things that happened during the pandemic, and will help us to come out of this pandemic stronger, which we all aim to do. Thank you for listening, and I'm now going to hand it over to our lead governor, Cecilia.
Good evening. I'm Cecilia Gould. I'm one of the 2 public governors for Oxford City, and I'm also the lead governor. I'd like to really thank you for taking time to join us tonight, because I'm sure, like me, you feel pretty zoomed out over the last, well, the whole course of the pandemic. It's very kind of you to take some time out this evening. Anyway, next slide. Who are our governors? Got some pictures here. Well, I was going to show you some pictures of our governors, but never mind. Our governors, all NHS Foundation Trusts have to have here we are. These are our public governors. I think the next slide will show you the staff governors. That's great. There are some vacancies at the moment. Anyway, next slide. Is that coming on? Yes. Who are the governors? All foundation trusts must have a council of governors, and the council of governors is chaired by the chair of the trust to ensure that there's good working between the governors and the board. At present, we have 16 public governors who are elected by the 7,000 plus public members, and we've got 6 staff governors, both clinical and non-clinical, who are voted and elected by the staff members. We also have 6 governors who are appointed by partner organisations. Elections are held on alternative years on a 3-yearly cycle to maintain continuity. Elections have been delayed due to COVID, but we had some earlier this year, and further ones will take place early next year. Now, what do we do? I must say, it all sounds very formal. The formal definition is we hold the non-executive directors individually and collectively to account for the performance of the board of directors. What is a non-exec director? Or they're, as they've referred to commonly, NEDs. Well, fundamentally, the NED's role is to give independent oversight to the board by providing dispassionate and objective criticism. They're not involved in the day-to-day management of the hospital, but they all have significant experience and expertise at senior level in areas relevant to the board's work. Now, basically, the governor's role is to ask them how they work with the executives to ensure that patients are cared for to the highest possible standards, and that the staff are given appropriate training and support to enable them to do that. We are working to represent the interests of the trust membership as well as those of the public. We're also responsible for the appointment of the trust chair and non-executives. And as you heard Jonathan mention earlier, we've appointed 2 new NEDs. Ash Soni, he's a pharmacist holding a number of national leadership roles, and Joy Warmington, who's an expert on organisational leadership and development. We've reappointed our trust chair, Jonathan, for a further 3 years, and we've also reappointed Anne Tutt, who is vice chair, for a further 3 years. These are valued reappointments. They were made to ensure that continuity is maintained at board level following the arrival of the new NEDs. We also undertake an appraisal, or we receive the appraisal of the chair and the non-executives. These are reviewed fully by the Council of Governors. The other thing we've done in the last year is review the trust constitution to get it up to date. One change means that with effect from January of this year, the Buckingham, Berkshire and Gloucestershire and Wiltshire constituency increased its representation by 1, which will increase the Council of Governors to 30 plus the chair. Governors can now stand for 3 terms of 3 years, whereas previously a maximum of 2 terms was permitted. Also, we thought that non-executive directors could be reappointed for 3 terms instead of 2, if it's deemed to be in the best interest of the trust. Next slide. We go on next slide. Yes, trust membership. At present, we've got quite a few members here, over 7,000 public and 12,000 staff. As a member, you'll receive information about what's happening in the Trust Hospital. You can be eligible to stand for a governor and vote for who will represent you. And you'll be invited to attend meetings and events, which hopefully will become more frequent as this pandemic subsides. I'd like to reassure you there's no obligation to do anything. And you'll find more information on the Trust website, which the web address is there on the screen. Next slide, please. Oh, we haven't got a next slide. Maybe I've overdone it. Anyway, we're very, very aware as governors that we've had very limited opportunities to meet both members, staff, patients and relatives. All our meetings have been held virtually since the onset of the pandemic. And recently we have been discussing how best to restart some of them in public, hopefully with public members able to attend. We're waiting for expert advice on how to do this safely. All our papers can be found on the OUH websites, and meetings are now being recorded so that all members are able to see what takes place. We would like to reassure you, though we haven't been terribly obvious in our meetings, that we are working hard to support the Trust, its patients and its members, with particular emphasis on maintaining patient safety and the recovery of normal services, of course. But, you know, as Bruno mentioned, we have been very keen to know about staff well-being and how this is being looked at. Finally, this is my last bit, but I'd like to thank all those who voted in the governor's elections and those who stood for them. Without this, you know, the Council of Governors will not be as strong as it is. Also, can I thank any past governors who are listening? Thank you so much for the significant contributions you made to the council, to all its work, and thank you so much. Anyway, that's enough of me. I've done my formal bit. Over to Jonathan to and he'll handle and chair the questions. We've had such limited opportunities to meet the members of the Trust, and this is a very important opportunity for us to hear from members and staff. Thank you very much. Jonathan.
Thank you very much, Cecilia, and thank you to all your colleague governors as well for the support, but also the challenge they've given over the year. We're now, before the questions, going to hear a video about the pioneering long COVID service that was being developed jointly with our colleagues from our sister trust, Oxford Health. We've heard a lot about the immediate impact of COVID, but even when people recover from the acute phases of their illness, there are long-term effects on many of our patients. So this is a really important service for us to develop that will be impacting, I'm sure, on many of the people listening or people that they know. So, Chris, can we have the video?
I woke up unable to breathe and really quite scared about it. Felt like there was an anvil on my chest, really heavy compression on the chest, a lot of pain shooting along the left-hand side and down the left arm, difficulty breathing, really hard to breathe, dizziness, fever, nausea, tinnitus. You know, it was all kicking off really at that point.
Long COVID is essentially like a blanket term, and it basically means anybody that has symptoms after 4 weeks from becoming unwell with COVID. Post-COVID syndrome tends to be a condition that is defined at around 12 weeks in those patients that have persisting symptoms following COVID, and those can be very far-reaching symptoms.
At that 12-week mark, when symptoms are really starting to sort of embed, that's when we're accepting referrals into our service.
Every day was like a nightmare because it was I felt like I was being strangled and suffocated. What I've learned about this illness, it hits different parts of you as an individual, whether that's psychological, mental or physical.
Very, very early on, it became apparent that the after effects of long COVID were really, really far reaching and often affected those patients who initially had quite a mild initial illness within the community. That realisation came that it needed to be a service that actually was able to manage the full range of symptoms and symptom burden for patients.
It's really important to have contact with the GP, and the GP is able to signpost to services more locally, especially thinking about psychological therapies as well, if that's important at the time.
And the emotional impact's been huge. I remember in April when I just wasn't getting any better at all. I remember sitting on the end of my bed and just crying because it was non-linear. There was no end to it. I just waking up every day feeling like I was being strangled, and that was if I could actually sleep, because if you can't breathe properly, it's really hard to sleep. And I wasn't sleeping, and of course you need sleep to heal, and the emotional impact's been huge. I felt really quite low and vulnerable and lonely and on my own.
Being unwell with anything has an emotional impact. I think being unwell with COVID has had a significant emotional, psychological impact, because clearly there's been a huge amount of worry and concern about COVID over the past 18 months. In addition, some of the symptoms themselves are quite frightening. Breathlessness, for example, being a key one.
It felt very holistic to me. It felt like each part of the system was talking to the other part. Also human touch. There were people who cared and wanted to help. It relieved that one of the major symptoms that was causing me a lot of distress, because anyone with asthma or anyone with breathing difficulties will know that if you can't breathe properly, there's not much else you can think about. Talking about how this had made me feel, there's probably some post-traumatic stress going on, which I understand that from the point of you not being able to breathe for 6 months and regularly having nightmares and having insomnia. There's a lot to talk about there.
In Oxfordshire, we're really ensuring that each individual gets a full holistic assessment, and what I mean by that is a full sort of recognition of all of the medical issues that they may be having, but then also addressing sort of what their goals may be in terms of returning to work, returning to exercise, and then also thinking how that's affected them psychologically.
The other elements of having clinical diagnostics, having lung spirometry, having more CT scans, having CPET test, which is where they look at they put your lungs and heart under stress together and see whether those two organs are working in tandem. But it was really great to have a reassurance that my heart and lungs were working okay. They gave me a series of objective, measurable indicators that told me my body was actually okay. That to me was hugely helpful.
We're able to provide people with some really useful tools and strategies to manage all of those symptoms so that they can then return to work and to family expectations and to exercise and that social interaction that they were completely used to.
We are seeing people recovering. We know that being patient with your recovery process is really important. Keep focused, keep thinking one day ahead. What are the one or two things that I can do? Focus on things that you can get some pleasure from. Have something that you can kind of look forward to, even if that's something very small.
There are no boundaries within long COVID because it's unknown, and so the opportunity to be able to work and to try different things and to be able to really listen to patients and understand what it is that they want and what they feel is appropriate, and that's really helped the development of certainly our services.
It really is kind of a multidisciplinary collaboration. It involves not just kind of the hospital team, but the community team, so that people can start their kind of recovery journey in the clinic and then move on to the community so that they can be followed through and supported the whole way through their kind of recovery, or at least to a point which actually enables them to kind of self-manage their illness.
Individuals, survivors, they want a pathway. They want to know what's next in the treatment of me as an individual, and knowing that there were tests on the horizon, there were things that were coming up, knowing that there was a pathway for me was huge, because in those first 2 months there was nothing. I just sat on my own at home going, am I dying? Once you get a series of steps in place that help you see through, it's almost like a map, right? It helps you to see through a very difficult time. That made a big difference. It's very positive.
Part of what we're trying to do in clinic is understand people's symptoms more holistically, and then trying to devise individually strategies that we think are most likely to be helpful for that patient. People, when they can engage with some of these strategies, if they're the right strategies and they're applied in the right way, people are improving, and I think that's really reassuring.
You know, you're not alone. There are people in Oxfordshire who can help and will help and are trained to help, and there are steps you can take to become better and to understand more about how this illness is impacting on you. And you know, knowledge is power, isn't it? And I think what the long COVID service has done is has empowered me through providing me with knowledge about what the illness is doing to me as an individual.
The most important message for people with long COVID is to learn that you can't push. You absolutely cannot push and challenge out of this. This is you have to listen, you have to sort of respect and respond to the body, and the more you push and challenge recovery, the more it rebels and the more it pushes you back down.
I think what we have learnt in the service is that people do get better, but there is no quick fix. And you know, and it's a long journey, and people do need to be patient.
I know I'm going to get better, and I will get better. It's going to take time, I think, is where we're at. But I've no doubt that in a couple of years' time I'll look back on this period and think, God, that was tough, but yeah, I'm through it.
Well, I'm sure you found that challenging and hopefully also informative about a part of our services that we run in partnership with Oxford Health, and which I'm sure we'll hear more about as we go forward and learn more about the impact of COVID on people's lives. Now, this is the time that we'll do our best to answer the questions that you've posed to us. If we were physically together, it would be easy for me to see what people were raising. So I'm relying on things that you have put into the question and answer function on the meeting, and also things that have been sent into us in advance. We won't be able to deal with particular personal issues in a public meeting, but of course we'd be very keen to hear from you if there are things that need to be sorted out individually. I'd like to pick up one of the questions that was sent in advance to start off this session, and that was a question in relation to our maternity services. We've had a recent visit from the Care Quality Commission and a published report, and I'm going to invite Sam Foster, our Chief Nursing Officer, to open up on that, but also subsequently to pull in Professor Tony Shapira, who is the NED lead for this area. So Sam, I'll pass over to you now.
Thank you, Chair. And just to share the nuance of the question, it was in relation to the results of our CQC report and really the responsibility of the board and which non-executive had specific oversight of maternity. So I think the first thing to share with the public is the CQC report was not a surprise to us, which I hope the public will find reassuring. Whilst we were extremely disappointed to have our ratings reduced, there were a number of areas highlighted in the report that we were already focused on. It highlighted issues around our environment, and the public will know that it's a very old building. So there's a limit as to what we can do to improve, but we're working with our Maternity Voices partnership to think through innovatively how we should be able to improve the environment for women and their families. It talked about our ability to improve documentation and risk assessments, and that's another key area of focus. I'm working with David Wallaker, our Chief Digital and Information Officer. We are in process of procuring a new electronic patient record and system for our maternity services. There were a couple of other key issues which were identified and remedied on the day concerning issues around out-of-date medicines, and a couple of other issues that we were able to actively remedy on the day, as I say. The public will also note, if you've read the report, that there was an inference around culture, around whistleblowing. And I think that I can assure the public in saying that there were a number of staff who used our freedom to speak up processes and did raise concerns, and the Trust already had an investigation in process. That investigation is still live. I'm not able to share any outcomes publicly, but I can give assurance that those concerns are being investigated in line with Trust processes. What we were really pleased about is the improvements that we'd made since our last visit from the CQC, particularly around our workforce, their training, the real inference to the right people in the right place at the right time, our management of patient safety, incidences and safeguarding, and our ability to deliver holistic care to women, their babies and families. It made comments around leadership. It commented that leaders ran services well, and it also talked that most staff felt respected, supported and valued. So in terms of the question of how we govern our maternity services, we govern that in terms of a unitary board. We have a line of sight from ward to board, and that is where the service will report to their divisional senior management. As executives, we have a trust management executive chaired by our chief executive, where we review maternity performance and quality and finance issues. And then there is board reporting, which is done in public. We're also accountable to a regional service and to our public by the MVP, the Maternity Voices Partnership Group, that we regularly interact with. What's slightly unique about midwifery services is there's a requirement for board, both executive and non-executive safety champions, and I'll hand over to Tony in a moment, but Tony Shapiro and myself undertake that role and meet the service on a monthly basis. We've also had the maternity services and neonatal services, in fact, presenting at seminar session with the whole board. So in terms of next steps, we are required to produce an action plan for the CQC. Our actions are well underway. I gave a flavour of that to our governing body last week at our Patient Experience Committee with the governors. The service are very pressurised at the moment. This is a national issue with elements of the service suspended. So we're bringing in some additional strength and support to continue that engagement and improvement journey. And that will be led at executive level by myself and Terry Roberts, our Chief People Officer, and very supported by our non-executive directors, both the chairman and Tony Shapiro. And Terry and I will be feeding back to our Chief Executive of the progress of that. So I'd like to hand over to Tony Shapiro, our non-executive director colleague and maternity and neonatal safety board champion.
Thank you very much, Sam. And I can only reiterate much of what you have said about the CQC report. They highlighted areas which we will focus on, in fact, have already started on that and are well underway to improve our service yet further. And it's important that we do that as quickly and effectively as possible. But they also importantly highlighted a number of areas that you discussed. Most importantly, that the service was safe and the staff were well trained and managed a number of areas with great respect to the patients and provided good support. So there was much to take away that was positive from the report, not to say that we shan't be focusing on improving the whole service along the lines that they suggested. So we do have good sight from the board, and you and I and your colleagues in maternity meet on a regular basis to help make sure that everything proceeds to ensure that this service is of the highest quality. So I'm confident that we will move forward from this and the board will support you and all the staff in doing that.
Thank you very much. I'm sure there's much more we can say about that, but we have a large number of other questions that have been raised. So I'd like to move now to my colleague David Wallaker to pick up a question that's been put in from a staff colleague around some of the challenges about our computer equipment and the way in which we have a proposal to reprovide as necessary to make those machines work effectively for people. So David, over to you to pick that one up.
Thanks, Jonathan, and thank you everybody for taking your evening to attend. So my name's David Wallaker, I'm the Chief Digital and Partnerships Officer, and this question really related and specifically to the Churchill, but I think we'll address it from a general perspective, but specifically to that question. So we've spent a lot of work and time over recent months and years upgrading our computer estate. So that's upgrading the version of Windows and the security controls around that. But a lot of this really depends on a fast and reliable network. So think of this like at home, where you might have a couple of devices, a couple of phones, and maybe a television connected to your broadband. If you've got a bad network, you'll soon notice it when your films or streaming buffers. And this is the challenge we face from a trust perspective. So we have about 10,000 laptops and computers, about 15,000 mobile devices connecting to our network every day. So we've invested a multi-million-pound upgrade to our network. The board has acknowledged that this underpins all the digital transformation we're trying to do. And this is then key to a lot of the improvements that people will notice then on the ground. So we've started that, and it will be finished this financial year. So by that we mean by March 2022. And for the Churchill specifically, because that's where the question related from, that's in effect about an upgrade to about 44 network switches. So they're the boxes that make the network work. Hundreds of network access points, that's the Wi-Fi that allows you to connect. And this is planned for the Churchill to be completed in December. In the question was also a question around bedside devices, and this is a system called Send. There was two parts to requirement to fix this for everybody. So the first step was to upgrade it to a version called 9.1, which is compliant with the new News 2 nurse and observation, and that happened earlier this year. But that really relies on the upgrade to the network before we'll see the real benefit. However, we are replacing all those devices as well with iPads. So these are better, quicker, more reliable, and indeed cheaper devices that are there currently, and they're rolling out in batches. We're not going to wait till the network upgrade's completed there. You won't see the real full benefit until it is completed. The next round of upgrades for Send is due in October, and it will finish early 2022, so maybe February next year. And there was also a point in the question around computers on wheels. And again, we've made a multi-million-pound investment in these across the trust, of which 78 specifically gone to the Churchill, about 25 to theatres and 54 across other areas. But you may notice some old computers on wheels hanging around. Some of that's to do with we want to refurb them. We want to replace the computers in them where possible, or the batteries. And of course, the ones that aren't good enough will be retired to the computer on wheels in the sky. So I think in short, we acknowledge that maybe sometimes the devices haven't been as quick and as reliable as people would have hoped for. We are working hard to do that as a trust, and the board has made significant investment in this area, but it will be a few months before we see all the real benefits across the trust.
Thank you. Thank you, David. And I will stick with the IT a bit, and I'll come back to you in just a moment, David, but I'm also going to pull in after David, Dr. Annie Sykes. And this was an issue that came up both in advance of the meeting and also during the Q&A function that we've got on the website. And it really relates to what we've learned during COVID about the use of virtual consultations and how we see that going forward. So I'm going to invite David, you first of all, to speak about our general approach to that, but then to pass over to Annie for a clinical perspective on how this works for individual patients. So, David, what is our policy about the continuation of virtual consultations?
So yes, thanks, Jonathan. Before we get to policy, it's probably worth just framing it. So at the beginning of the pandemic, we, along with other healthcare providers in NHS and social care, deployed virtual consultations at pace. And what this meant for our patients was the use of video consultations, really, because we already provided telephone consultations, but it was to do it at much more scale. And as we've moved through the pandemic and hopefully into more normal times, we're working hard to ensure that we have clinics which are called blended. And what this means is that appointments, be it face-to-face, be it video, or be it telephone, are scheduled in one clinic. So this makes it easier to ensure that the right clinical information is available for our clinicians who are providing the appointment. It's better experience for the patients, and it does reduce our administration costs by having it in one place. So it is our intention, our policy, to keep virtual consultations, but only where they are suitable to do so. And we've been very careful to ensure that this approach doesn't impact on the quality of either the quality or the experience for our patients. And the choice of consultation type will be based on clinical need and patient choice. And I think if I could ask Annie Sykes, who's here representing the Chief Medical Officer, who maybe might be able to explain how that clinical need is evaluated and decided on an individual basis.
Thank you. I would echo those comments in that the virtual consultations have been really vital in our response to COVID, in keeping certainly our cancer service and other non-COVID business going during the last year. The blended clinics, blending both non-face-to-face and face-to-face consultations, do give us an opportunity going forward to really get a balance for the people who do prefer non-face-to-face and can have their needs met by this, with people who we do need to see face-to-face. These decisions are made individually by clinical teams. For new patients, this would be at the point of triage to establish whether or not a face-to-face or non-face-to-face consultation would be appropriate. And for patients who are already in our follow-up clinics, this would be done in the weeks prior to an appointment, where individual clinic lists are reviewed by the clinicians to decide which patients would benefit most from non-face-to-face and whether patients do need to be seen in person. Now, clearly, although these decisions are done individually reviewing cases, there are sometimes conditions such as perhaps being very hard of hearing that would mean a face-to-face consultation would be better. And if those situations are not clear from the records, as sometimes they aren't, then people do have the opportunity to contact departments to request a face-to-face consultation if needed. So I think, like most people in the pandemic, we are finding our way with the balance here. But going forward, I think the non-face-to-face remote consultations are going to continue to be an important part and a very useful part of our armamentarium. So I'll hand back to you, Chair. Thank you.
Thank you very much, Annie. I'd like to stay with some of the challenges of providing services, and there are two questions that have come up during the meeting around the relationship between our services in the acute hospital and social care. How we make sure that we join our services up for the residents of Oxfordshire, and how we make sure that vulnerable patients' discharges from hospitals happens in a timely and safe manner, particularly bearing in mind changes in providers that are on the horizon. And Sam, I think you're best placed to pick up the answers to those two questions.
Thank you, Chair. So I'm just going to rewind a little bit for members of the public and think back to 5 years ago when the CQC did a system inspection, which was primarily focused on enabling residents to have a safe and effective discharge out of hospitals and how the system was working together. And I think it's fair to say it was a less than favourable report around poor relationships which were impacting on patients. I think as we roll forward, we've really focused on our relationships with colleagues across the system. And by the system, I mean colleagues in Oxford Health, Oxfordshire County Council, the ambulance service, colleagues from charity organisations such as Age UK, and their relationships that have been forged at chief executive level through to service level. So we have a joint objective as a system around safe and effective discharge, and we connect every single day, 7 days a week, with colleagues from the organisations that I've mentioned, first thing in the morning, again later if required, and as I say, throughout the 7-day period. So we have a couple of key actions in process that we're working on. I am the joint urgent care lead with the Director of Adult Social Services, and I chair a fortnightly meeting, System Urgent Care. I also chair the A&E Delivery Board. And then I have the opportunity to feed back and escalate issues to our 4 system chief executives, which we did so last night. So the 2 key areas of improvement that we're working on are badged under 2 national priorities. The first is called Ageing Well. That's led by Oxford Health in partnership with ourselves, and that's primarily focused on preventing patients from requiring an emergency department attendance with an increased community services response time of less than 2 hours. So that's rolling out and in progress and escalating up as part of our winter plan. The other area of focus, which is pertinent to the question specifically, is under the Living Well at Home umbrella. And that focuses on reablement following discharge from hospital, provision of domiciliary care and provision of assisted living. And we're working, this is a very live issue, we're working on that transition as partners at the moment, managing those risks, which really do focus, as the question asks, around workforce constraints. So we're assessing the increased need for the demand in the community. We're working with our commissioners, and we're really trying to look after our staff, retain them in the health and social care domains, and as I say, work with partners to enable that transition to be well managed and risk assessed. On top of that, we're winter planning, and we're just going through the process of allocating additional funding so that we can ensure that capacity is in the right place to care for patients and smooth the discharges. So the question was really very much around what is our biggest challenge. Our biggest challenge is workforce, which is why the focus is very much on really protecting the health and social care workforce across our respective organisations with good recruitment and retention packages and clear pathways to enable staff to do their job for residents and patients of Oxfordshire. And I hope that answers the question, Chairman.
So thank you very much, Sam. And it sort of throws open the next one I think we should go on to, which is around the well-being of our staff and staff retention. So there's a general question that's been posed about our approach to recruitment, retention, and also some quite specific points about how tired staff were at the beginning of the pandemic and through the pandemic. And I'd like to invite Terry Roberts to pick up that question. And Terry, are you? I think you're ready to take it now. Thank you.
Thank you, Jonathan. So my name's Terry Roberts. I'm the Chief People Officer. Good evening to all of you. And I'm going to address the questions around recruitment and retention and what's our strategy around that. And first thing I want to say is that recruitment and retention is a key part of our overall strategy as a trust, and it's also a significant part of our people plan. And when we look at recruitment, we kind of have a 4-point plan. The first is about making sure that we focus on our domestic market and that we work with our colleagues in our ICS, our integrated care system, to attract people and to ensure that we get people to come and work for all of our posts. The second prong is around international recruitment, and Sam Foster, the chief nurse, has been doing some great work with her team to make sure that actually we get a large number of international nurses, and we're also broadening that out to allied health professionals to meet the needs that we can't be met here because we're not training enough of our nurses, we're not training enough doctors or allied health professionals. The third point is around retaining our students, those students that come and work here. We're looking to ensure that actually they stay here and that we have a high retention rate. And then the fourth point is around our new roles and apprenticeships. We want to grow our own people, and also we want to attract people into apprenticeship roles so that they can come in not only after school, but as adults and train and become our new members of staff. So that's kind of like the basis of our recruitment strategy. In relation to retention, we've recently developed something called Growing Stronger Together, and you would have heard Bruno talk about it earlier on. And there's a 5-point plan there. The first is around meeting the immediate needs for rest and recovery, and that's quite simple things like ensuring that annual leave is taken. But actually, that might seem simple, but actually our people are really hardworking, and our people don't take their leave. So actually getting them to take the leave is actually something that we really have to work hard at. Also making sure that we have adequate rest breaks for staff and that people have opportunities to de-stress. Within that, it's also around things like signposting to our wellbeing offer, and also our newly created wellbeing leads role. And we also think that it's important under the whole immediate needs for rest and recovery that we have opportunities for reflection and commemoration, as Bruno highlighted in some of the things that we're doing in relation to the coffee book, etc., etc. The second point is around building a culture of learning, compassion and inclusion. The third is around facilitating post-traumatic growth, and this period under COVID has been quite traumatic for some people, and we've developed and implemented a 3-part support package we call our R3P, which we've developed from the MOD to support our teams together to make sure that they don't suffer. We've also introduced structured wellbeing one-to-one conversations for all staff. The fourth point is around supporting sustainable service recovery and workforce planning. And so we're trying to balance around service recovery and individual team recovery. And the final point is around building working lives that have more flexibility and autonomy. I think I'll stop there, Jonathan.
So thank you very much, Terry. I'd like to go back to patient issues now, and there's a question in the chat in the Q&A, but we've heard it a number of points about where we are with our recovery post-COVID, and in particular those services which are not yet open to new patient referrals, particularly cataracts and ENT services. And I wonder, Sarah, if you can update us on where we are and why it's taking so long and when those services might reopen.
Thank you, Chair. Good evening, everyone. My name is Sarah Randall. I'm the Chief Operating Officer. I think just to put it in context, our total waiting list size for outpatients for the diagnostics and those patients waiting for treatment is around 50,000 patients. We've gone up about 10,000 patients since the beginning of January, and those patients over 52 weeks around March time had reached around 5,000 patients. What I am pleased to say is through the focus of really looking at those long waiters, those long waiters have actually come down to around 1,800 at the end of August. We particularly had some most challenged specialties with high volume, and were also affected by the infection prevention guidance in treating those patients with ENT, ophthalmology, and also oral max fax. So those specialties at the moment still remain closed. In ophthalmology, it's just within cataract services, whilst we're really focusing on the emergency and urgent care for patients for cancer. And so those routine patients for those specialties are closed at the moment, but we do have alternative pathways for those patients. They can go to other NHS providers and also the independent sector. Our focus has been looking at the clinical priorities of the surgical waiting list, particularly what they call P2, that the priority 2 urgent patients that need to be treated within 4 weeks. So those have been a particular focus, and looking at making sure that they're done in a timely way. We've also prioritised diagnostics, so those patients that need to be treated and seen both in radiology and also endoscopy to bring those weights down. And indeed, we are bringing those weights down, which is really great. We're working across the system with system partners to look at both ENT, ophthalmology and orthopaedics, to look at how we work together, to look at our capacity in particular, both within outpatients and diagnostics, and also within theatres and across all of our services. We've ensured that we've got patient harm reviews for patients particularly waiting over 52 weeks, and those have been done on a regular basis. And we've just started a digital rollout for patients to be contacted to make sure that they still want to be maintained on our waiting list. So going back to ENT and particularly cataracts, so although that we remain closed just to routine referrals, the waits are still remain high, but we are very focused and working with the services to looking at a plan to reopen those services in the near future. But we are really focused in making sure that the patients are being seen and other providers. I wanted just to really thank all the services that worked really hard to reduce the backlog for our patients. And I think that hopefully answers the question, Chair, so I'll pass it back to yourself.
Thank you, Sarah. I think that one will run for a while. But I'd like to go back to some quite specific questions about staff wellbeing that came up in the chat. Terry, you talked about the general approach and a range of things we're doing. There were two very specific things. One was we are encouraging people to take their leave. Do we know whether that's actually happening or not? And it's clear from the question that it's not felt to be as easy to do in some areas of service as we would like it to do as the board. And the second is the length of shifts that people are working and whether that length of shift is an effective way. So I think I'm going to start with you and if other colleagues want to add to that question, perhaps they could let me know and warn me. So Terry, to you first.
Yeah, I think I'll ask Sam to come in on the length of shifts, but in terms of annual leave and do we know people are taking it, well, we're monitoring it, and actually it's part of our divisional reviews. So some areas are meeting our target, which is that 80% of their annual leave should be booked by the 1st of October. And we're monitoring that and we're reviewing that, and that's going to be part of our next divisional review meeting. So it's something that we've tasked divisions to do. Some are doing better than others, if I'm really honest with you. But we have made it a target. We've got our divisional leaders looking at that and working with their HR business partners to make sure that that's happening. I'm wondering whether it'd be worthwhile, Sam, you coming in and talking about lengths of shifts.
Thank you, Terry. So this is not isolated to nursing. Our nursing and therapy staff are all on the Trust electronic roster system, and we've also got an electronic rostering policy, which puts some controls in to support staff. So there's quite a bit of evidence around the pros and cons of 12-hour shifts, but our staff preference currently, having surveyed staff, is that the 12-hour pattern is a preferable pattern. It enables colleagues to support childcare needs. It enables colleagues to work for 3 long days a week if they're full-time and have 4 rest days. The policy does dictate that we shouldn't work more than 2 12-hour shifts in a row, and there, as I say, are controls and alerts if we roster outside of those rules. So it's an area that we frequently look at. It's imperative that staff take their rest breaks during their 12-hour shift, but currently it is the preference for our staff that they work 12 hours. I have to say that staff that wish to work the shorter shifts or the traditional shifts of 7.5 hours a week are also able to work those shorter shifts.
Sam, please don't go away, because I'd like to invite you to pick up a few thorny issues that I think are long-standing questions that have come up, and I think there are 3 in the chat that it would be good for you to just comment on. There's one around the procurement process, and particularly something sent in about chairs that might not have been procured in conjunction with the physio staff who are using them at the knock. I don't think we've heard about the knock before this evening. Second one was about generally responsibility for cleanliness, and however hard you try, there are always examples where things are not as good, and we would like to hear a bit about the system for that. And then I'm afraid there's a thorny one about car parking as well. So perhaps I could give you the mic back to pick up those, because sadly for you, they're all within your remit, I think.
Thank you, Chairman. So we've got the 3 C's. I will start with chairs. So really good piece of news. Last year we procured 1,100 new patient chairs. Due to the procurement and the availability of supply, 75% of those chairs were height adjustable, which was felt by the advisory group, which did include physiotherapy, the back care and manual handling team and the tissue viability team, as well as other clinicians. They felt that that met the need of our patient demographics. This has been a significant improvement on our old stock of chairs. However, if there are issues, say at the NOC, for example, then I will follow this up and have a relook, because we should have sufficient chairs within the organisation that are height adjustable, and we can swap those out in areas where we've got more ambulant patients. So that's something that I'll pick up outside of here, but I think a really good news story that we replaced 1,100 patient chairs last year. I shall now move on to cleaning. So the question was specifically from a member of the public raising concerns about some cleaning concerns that they had. So I think we must start by saying this is critical for safe care and critical for our reputation. I'm the board lead for Soft FM, which is facilities management, and that's portering, catering and cleaning. And this is provided across our trust, across our hospitals, by a number of providers, including trust employees and colleagues from PFI teams. And they deliver cleaning services against a national specification. The cleaning standards are monitored at least daily, more frequently in high-risk areas, and there's the ability for members of the public and staff to escalate 24 hours a day where cleaning's fallen below standard. But we've got some new developments this year. There's a real focus on improving our soft facilities management. So for that reason, as a trust, we have increased and strengthened our team. First individual that I can share with you who's been appointed is Caroline White, who was one of our cardiac matrons, and she's taken up a new role, clinical lead for hospitality, and her role will interface with our cleaning, catering and portering colleagues and our clinical staff to ensure that we can really make the improvements that we wish to and maintain the high standards that we wish to, as well as some additional contract managing staff. I think the other thing to say is that COVID caused the pausing of the place assessments, which is something that we very much valued members of the public and governing bodies support with. And we're just about to relaunch our place assessments in the coming weeks, just waiting for some final national advice via a webinar next week. But we will be relaunching our place-based assessment, which is patient-led assessments of clinical areas, looking at all of those soft facilities management areas. And then I'll move on to parking, which we couldn't have had an AGM without talking about parking. So parking sits again within my portfolio, but we've got a great team, a great travel and transport team who Bruno recently met with to talk about the thorny issues for our staff and our patients. This is an area that we're really working with the County Council with, and also an external travel consultancy company. The question was specifically around increase in population and increase in centralisation of certain services and the impact that that's going to have on parking. So I think I'd just like to share we've been implementing a number of changes since last year. Members of the public may remember we took a board story in the outcome of our car parking survey with the public. We've been busily implementing automatic number plate recognition to ease the flow, improving lighting and road surfaces, and increasing our blue badge spaces over the last year. We really do need to now just take stock again and review the travel patterns and working with our bus companies and the County Council to consider the next phase of our options and improvements. Because I think it's fair to say there is a consensus that logistically we think that we can continue to do better. So I'd watch this space, I'd contribute to the next public questionnaire that we'll be putting out, and we'll need to see some continued improvements. But it also does map into the earlier conversation around virtual consultations and really trying to decongest the main hospital sites by using park and ride alternative transport or other technologies where we are able to offer an alternative to attending site.
Thank you very much, Sam. I want to try and move to some of the forward-looking questions first of all, and we had in the question about Catherine House and the benefits to us and Catherine House from the work we've been doing together and taken on board. I'm going to ask Jason Dorset to pick that up first, and then there's a set of questions, bigger questions about our sites, the Horton and the JR, which I'll turn to Bruno. And it may be we don't get much beyond that, I fear, in the time we have left. So Jason, on Catherine House, please.
Thank you, Chair. I'm Jason Dorset, I'm the Trust Chief Finance Officer, and I was the executive sponsor for our project to put together a partnership with Catherine House last year. For those of you that don't know much about Catherine House, it is a hospice located outside Banbury on a beautiful site and delivering a much loved service to the community in North Oxfordshire. It provides 10 beds of palliative care for patients close to the end of life, but also a range of community and outreach services. And picking up the question about what the impact would be, I think in the short term, we would actually hope that the patients that Catherine House Hospice serves don't immediately notice the new partnership with OUH that has seen OUH take over the running of all of the services from the 1st of April. There was no problem with how Catherine House was serving its population that needed fixing, but the trustees approached us because they took a medium-term view that the future of standalone hospices in the coming years was going to be increasingly hard to sustain, and they knew that OUH, rather unusually for many large NHS organisations, already ran and operated a hospice, the Soho House Hospice, on the Churchill campus. So fundamentally, the partnership is about preserving something that's already working very well. That said, I think we hope that with OUH now providing both of the county's adult inpatient hospices, that we have a greater breadth of vision and reach across the county, and there are developments in the world of end-of-life care in terms of trying to provide more of that care to people in their own home, which we think we can do more effectively now that we're operating on a county-wide basis. So, as I said, there were no problems immediately to fix, but we hope, working with our new colleagues at Catherine House Hospice and also the independent charity that continues to fund operations there, that we can do even more for the future for the people in North Oxfordshire who Catherine House serve. And thank you, Jonathan. Back to you, I think.
Thank you very much, Jason. So Bruno, I think I need to come for you for some big questions about the future. There are a couple of specific ones around the Horton. There's one around maternity services at the Horton, and there's a question also about the expression of interest that we've recently put in to seek funding to develop the future of the Horton site. So perhaps I could ask you to talk a bit about where we've got to on those issues and how you see the next steps.
Thank you, Jonathan. Indeed, there's a couple of questions around the Horton and Banbury, but also questions on the John Radcliffe and Oxford and some of the constraints of being in Headington, and then also south of Oxfordshire with, I think, a similar theme that we have population growth in all these areas, in Oxford, North Oxfordshire, South Oxfordshire. And indeed, when we talk to local residents, there's a need for increased medical infrastructure or refurbishing or renewing existing infrastructure. So all these questions are, of course, dependent on capital investments, either refurbishing or building new hospitals, expanding capacity is what we call a capital investment. I gave in the overview a couple of significant investments the Trust has made. We have made those investments largely with the cash we had generated in the past years. With the recent NHS reforms, there are now capital limits which are imposed on individual trusts and also on the newly created integrated care systems. So we're now dependent on joint decision making around capital allocations and investments, which requires, of course, good coordination between all of the partners in terms of how we spend the capital that's made available to regions and systems within NHS England. To be honest, we are absolutely lobbying quite hard to lift some of those capital constraints, especially if we are able to generate cash or attract partners to help us with investing in new infrastructure. We feel we should be able to do that. So one answer to the question is that we're trying to change some of the rules of the game around capital investments, because there's clearly a need in North Oxfordshire, in Oxford itself and in South Oxfordshire, to keep investing in infrastructure. Specifically to the question of the Horton, the board has approved the expression of interest. It's all public, it's available for the public to see. What we have submitted to the sort of capital process around building new hospitals. Clearly, this will be quite competitive. There will be 8 capital awards for building a new hospital, and we're one of probably about 100 bids that have gone in. So it's extremely competitive. We feel we have a quite strong proposal for North Oxfordshire, exactly built on the population growth and addressing some of the concerns around maternity and the increasing birth rate in North Oxfordshire. But I can also understand that people living in Oxford and using the John Radcliffe would like to see expansion of the capacity. We are looking at opportunities alongside the Ring Road, and with system partners we are also looking at South Oxfordshire, because there is indeed, as Lily was posting, a significant population growth in the south of the county as well. So fully aware of the need, somewhat constrained, or I would say significantly constrained in terms of the capital that is available, and even if we have cash available, some constraints on us being able to actually spend it on capital investments. So this would be, I would say, a story that we can pick up throughout next year, and certainly give another update at the next AGM. But I can assure you that the board is fully aware of the needs and is doing all it can to attract capital to Oxfordshire for these important expansions in medical infrastructure.
Thank you, Bruno. We're slightly over the time, and I know that we haven't quite answered head on all the questions, and we haven't quite got around to all the questions, and I know that my colleagues are busy trying to get answers into the reply function on the Q&A. We will, if you've left us the ability to do so by identifying yourselves in the questions, aim to get back with any information that we weren't able to provide to you. But I think this is the time which I should draw the meeting to a close. Can I thank you all very much for attending. Can I thank you for some very pertinent, well-informed questions, and my colleagues for working hard to try and answer them. There is a lot more information about the year that we're reporting on in our annual report and accounts, which you can find from our website. And may I particularly plug the book that Bruno mentioned, and the ebook version, Stories from the COVID-19 Pandemic, is available for you to have a look at. It is a moving account of the experience that our staff and patients have had through the pandemic, and I have been incredibly proud to be associated with those services, because people have worked hard and they've done well, and there are many people, probably some in the audience today, who have benefited from the care that's been given at Oxford University hospitals. But of course there are also others we've not been able to save, including, as Bruno mentioned, some of our colleagues. So it's been a sobering year, it's been a challenging year, and I'm very grateful to everyone who's worked in the Trust for the time, effort that they have put in to delivering compassionate, excellent care to our patients. We couldn't do that without the support of our members, our governors, and my non-executive and executive board colleagues. I hope you found the evening informative, and I'm confident that if there's stuff you still need to know, that we will hear from you. So thank you very much for joining us this evening, and I'll declare the meeting closed.